COVID-19. When you say these five letters and two numbers, everyone across the globe knows what you are referring to. It was and still is a common experience that almost all humans endured through. Yet, COVID-19 was not this quote unquote great equalizer. It was actually the exact opposite, as it elucidated health disparities among racial and ethnic minorities. Black people are 2 times more likely to die from COVID, and Hispanics are 2.3 times more likely to die from COVID than white non-Hispanic people. In December 2020, we saw a light of hope. The first COVID-19 vaccine was administered to a healthcare worker. The existence of a vaccine, though, came with an important question. How do you ensure equity in vaccine distribution during a pandemic that has disproportionately impacted marginalized communities? One way that public health officials have addressed this question of equity in the past is by targeting neighborhoods that have increased social vulnerability. The term social vulnerability is defined as the potential negative effects that a community endures when experiencing an external stress on human health, such as an environmental hazard, a natural disaster, or in this case, a pandemic. Living in a disadvantaged neighborhood has been linked to a number of healthcare outcomes, including higher rates of diabetes and cardiovascular disease, increased utilization of health services, and earlier death. When COVID hit, several states and cities across the US, such as Michigan, Vermont, and Philadelphia, quickly utilized CDC's Social Vulnerability Index, commonly known as SVI, to inform COVID-19 testing and vaccination allocation efforts. The way that CDC's index works is that it ranks US Census tracts on 15 social factors, such as crowded housing, lack of vehicle access, minority status, and unemployment, to determine the level of vulnerability of the area. And although CDC's index is the most commonly used during COVID, several other indices exist that were established by universities and federal institutions. It begs the following question. Why did most public health officials choose to utilize CDC's index? And how do you know which index is the best fit? Compared to other indices, I've noted that CDC's index does not address certain constructs such as healthcare access and quality, which would include the percent of the population without health insurance, or specifics on a community's social context, such as food insecurity. Yet, some of the other indices that exist do include these variables, but they may not have as much data available as a national protection agency such as the CDC. As more states and localities utilize these tools in their health systems and planning processes, it is extremely important to consider how these tools are being applied. My hope is that policymakers review and compare the wide array of indices available and the variables that they include, in hopes of comprehensively addressing social vulnerability and improving health equity. Thank you.